Good afternoon, and thank you for joining us today. Welcome to today's LA Health Collaborative, Equity in Healthcare, Reaching California's Reentry Population. My name is Crispin Delgado, and I am Executive Director of Insure the Uninsured Project, or ITUP. Before we dive into today's content, I have some important housekeeping notes for you. First off, this forum is being recorded and will be available on the ITUP LA Health Collaborative webpage. Attendees can listen to this webinar through their computers or by dialing in and using the number and passcode provided by the Zoom software. We also welcome you to utilize the closed captioning function. Just click on the CC button at the bottom of your screen to enable the live transcription feature. If you have any questions during this collaborative, you don't have to wait until the end of each panel or presentation to submit. We encourage you to submit your questions using the question and answer panel, which is also found at the bottom of your screen. When submitting a question, please indicate if it is directed at a specific speaker. We will answer as many questions as we can throughout today's forum. Also located at the bottom of your screen is the chat panel. Please feel free to use this chat function to say hello, introduce yourselves, chat with other attendees. We will also be posting relevant information and links throughout the forum in that chat feature. And we will also collect all of those links and share it with you after the program. For those of you who are unfamiliar with ITUP, we're an over 25-year-old health policy nonprofit and convener. We have three key focus areas. So the first is coverage and access, in keeping with our original goal of ensuring the uninsured. Delivery system transformation, including CalAIM, that we're going to talk about today. And the future of health and the health system. That includes some of our broadband and telehealth work. To advance our policy priorities, each year ITUP hosts a variety of convenings, including our annual conference and over a dozen policy and regional work groups across the state, from San Diego to Humboldt counties. We host online 360-degree forums and webinars, and so thank you for joining us today and being here. And we also publish in-depth issue briefs as well as high-level health policy fact sheets. This webinar today looks at an opportunity under the state's vision for making Medi-Cal more equitable. Under CalAIM, providers will be able to reach justice-involved Californians 90 days before they're released from incarceration. As many of us understand, this population is disproportionately Black and brown males. By focusing efforts to engage this population, it could have an impact on them as individuals, their families, and if successful, their communities. This is an important opportunity to reimagine what it means to reintegrate into communities and provide hope and tools to lead healthier lives and improve their chances of not recidivating. As you will find in this conversation, it takes a village of motivated leaders to shape how this benefit can be implemented at the local level. So it's not just an exercise. Detailed plans have to be laid out with community input to ensure we're all working towards an aligned goal. You're in for a treat today. We will begin the discussion by hearing from Los Angeles County Department of Health Services, followed by a reactor panel that includes community leaders. So with that, it is my pleasure to introduce Dr. Clemens Hong, as well as Shamsur Samra from the Los Angeles County Department of Health Services. Thank you for your partnership, and I will hand you over the mic.
Thank you. Good morning, or actually good afternoon, everyone, and thanks everyone for joining us. Dr. Samra and I are excited to be with you today and to share some of our sort of experience here working with justice-involved populations. So today we're just going to start with a little background, a little bit about how we got here, and then talk through some of our early implementation experience. And we want to save some time at the end for some questions and some discussions. So you really can't talk about caring for justice-involved populations without talking about systemic racism, our system of mass incarceration, and the major impact that this has had on these individuals and on our communities. This is what we're taking on when we work to improve the care of individuals who are impacted by the justice system here in LA County and more broadly. Really, the population incarcerated, as was stated earlier, is disproportionately Black, Indigenous, and Latinx. The opportunity really that we have right now is to leverage federal funds in this waiver, which is new, to help support individuals who are incarcerated as they come home from jail. And it really is a game changer, right? And holds the promise of improving health equity, keeping people home in our most marginalized communities, and helping depopulate our jails and combat this sort of system of mass incarceration. So we know that incarceration directly impacts health. For instance, people coming home have a 13 times risk of dying, with their risk factor being released from a carceral setting in 2 weeks. However, this population doesn't easily trust our systems of care, and engagement of these individuals is often the primary challenge in delivering health. So as an example, a provider can't take someone who's suffering from heart failure or mental illness coming out of jail and take good care of them unless they're willing to meet them where they are, to build trust and engage them first. And the individual needs to trust the provider enough to take the prescribed medications, whatever the treatment may be, or follow up with another trusted specialist or provider that they need to treat their heart failure or mental illness. And so our current system, unfortunately, is not always built for this. And really what we need to build here, what we need to kind of think about is how we deliver care in person-centered ways to these folks who are coming home, and really building a strong trauma-informed and really anti-racist system of care here in LA County and more broadly. So this really requires, and I think I'm alluding to this, a transformation of our health and social care systems, not incremental sort of improvement. We have to work to really build our community infrastructure and the capacity of our community-based organizations to care for these individuals in those trauma-informed and anti-racist ways. And it requires massive collaboration between partners because of the way these individuals meet and touch our systems of care. It requires partners from the county departments, cross departments, which that Dr. Samra will discuss with you a little bit of some of the work that we're doing with our health plans. And we've had great collaborations with our health plans to date. And with really thousands of community-based organizations with health and social care providers that provide care to these individuals, and do so from community roots and are able to engage them in ways that some parts of our system can't. So we're excited to explore a little bit of this with you today. So with that kind of background, I wanted to share a little bit about our journey here in LA County. But I want to start in San Francisco because I think there's a piece here from my past that's relevant. So as a resident in training, I partnered with another resident to develop a post-release clinic for individuals who are coming home from state prisons in San Francisco. We launched this clinic. It was called the Transitions Clinic, and started with engagement with community-based partners first. So we started with a community roundtable. This community roundtable guided us in the development of a model that focused on engagement through community health workers who have a lived experience of incarceration. This was essentially our engagement specialist. The piece that I was talking about as the primary need is to engage this population. And we saw, and there's been studies about this that showed that initial visit to the first visit in our clinic that we had created increased from 30% to 70% just by adding a community health worker with lived experience. So this individual, the community health worker, was integrated within a provider group that was culturally competent in serving this population with specific, that were able to deliver tailored care, and in a trusted community health center embedded in one of these communities. And the provider operated as much as possible in a trauma-informed, culturally competent way for this community. We also had a network of community-based organizations that delivered reentry and housing supportive services. And these pieces were critical to sort of making sure that the individuals who come home with an incredible wide variety of needs have the resources they need to sort of thrive as they return home. This model, which is founded on these close relationships with the community, really demonstrated a lot of different benefits, including a 51% reduction in emergency department visits, reductions in preventable hospitalizations by half in one study, reduced technical violations of parole and probation, resulting in 25 fewer incarceration days in the first year after release. And it lowered criminal justice costs in one study in Connecticut with a $2.55 ROI on every dollar spent. So this model is now a national model, has over 41 sites, including 21 in the state of California. And the Transitions Clinic Network, which is what it's called, is supporting our LA County health plans and supporting providers here in LA County as well. So I tell you this story because I think it sort of talks about a model that we know is effective, and one that could be something that we look towards scaling here. About 10 years after the Transitions Clinic was launched, we worked to build upon this model in LA through what was at the time the Whole Person Care Demonstration, a part of the last Medicaid waiver. LA County's Whole Person Care program invested in pre and post-release programs. So the pre-release piece was new, really to serve, and over the course of 5 years, served 25,000 people leaving LA County jails. The pre-release program, which is the new component, which served about 20% of those that were eligible leaving LA County jails, included an at-release Medicaid enrollment process, a 30-day supply of medications, and pre-release care coordination services that included a community health worker that would engage individuals on the inside and connect them to the community and to clinics and other things in the community that they needed. We delivered up to 90 days of pre-release services, and were paid for this through an enhanced care coordination payment that we received after release when their Medicaid was turned on. This was really the precursor to the state's 90-day pre-release program that you'll hear more about when Dr. Samra presents the early implementation opportunity. Our post-release opportunity centered around community health workers with a history of lived experience, again, building off the Transitions Clinic framework, working with numerous community-based partners across the county who would engage individuals coming home and in the community post-incarceration and link them to social and healthcare services. It was more of a social care focused model and to differentiate it from the Transitions Clinic model, but it allowed us to really invest directly in community-based organizations that could build that trust, or already had the trust, with individuals and help identify resources in the community, in their communities, that could best support these individuals. This was an incredibly strong part of the model. So as we launched CalAIM and Justice Involved programs, we're really building on the foundations of whole person care and really working with new partners, including managed care plans, to expand whole person care programs and achieve really the vision that the state has set forward. So CalAIM funds a first in the nation 90-day pre-release program that takes on the Medicaid inmate exemption and promises to sustainably expand and fund services we established during whole person care. It also allows us to serve up to 3 times the people we served at whole person care. So we believe up to about that. And then the post-release reentry enhanced care management programs allow for greater support to the individuals by adding a clinical component that was not possible with whole person care. And it creates the possibility of implementing in a sustainable way the types of models that we talked about with the Transitions Clinic. Finally, it adds a stronger clinical foundation to whole person care, both pre and post-release, and requires a warm handoff, including to behavioral health providers at release. So the CalAIM approach really creates an opportunity to scale models like the Transitions Clinic Network. We also need to do this thoughtfully and really being mindful of the incredible strength that we have in LA County in our reentry supportive services spaces. These organizations that have been doing this work for decades in and out and that are embedded in our communities and often best positioned to engage these individuals so that we can improve their health. So with that introduction, I'm going to hand off to Dr. Samra, who's going to take us through some of our early implementation experience and some of the key collaborations that we've needed and will need in the future to really bring these critical services to our populations. So, thank you.
Thank you, Clemens, and good afternoon, everybody. I'm just going to spend a few minutes here, hoping to leave a few minutes at the end for questions, but wanted to just give folks a little bit of context in terms of the LA County jail population and some of the work that we've done to date in terms of building off of the work of whole person care and moving towards the ambitions of CalAIM for this population. So to give people a sense, LA County jails is unfortunately the largest jail complex in the entire country. This is a census from just the last few days of number of individuals who are incarcerated. As Clemens mentioned, this is a racial justice issue in terms of the disproportionate impact of communities on communities of color. But stuff that's hidden in this data is that approximately almost half of the population is pretrial, which reflects the disproportionate impact on populations who are low income, but also some complexity in the fact that about half of the jail population can be released in about under 30 days. So there's a necessity to do a lot of work in a short period of time. In addition to the demographics, we know that there is high acuity of needs that are prevalent within the jails, including serious mental illness, individuals who are working through addiction, and individuals with co-occurring mental health issues as well as issues of addiction. There's a large unhoused population, a product of our housing crisis that's going on and the criminalization of the unhoused. It's been longstanding, but adds some complexity of reentry planning, and we know that many individuals have complex medical needs. We also know that the scope of Los Angeles County is not insignificant. These charts are a little bit complicated, but each dot essentially reflects one individual who's released from LA County jails over the course of 1 year. And the 3 charts going from left to right demonstrate increasing health complexity, so co-occurring health conditions. And you can see that the number of individuals being released from the jails and the breadth of the geography, what we're discussing, creates tremendous opportunities, but also tremendous challenges in terms of building up community-based systems of care that are able to receive folks who have been system impacted and work with them longitudinally. So just again, very briefly, I want to run through some of the key areas of work where we've been establishing partnerships and laying the groundwork to get to where we want to go when it comes to CalAIM's ambitions. So for pre-release services, we recently received word that earliest go live that we're able to, kind of get this process moving is October 2024. But this is really an entirely new area of work, which is going to allow all of the services that are listed in this box on the right-hand side of the slide. Really, it's going to provide us an opportunity to bridge what has historically largely been siloed work. There's care that's provided in the jails and the carceral settings, there's care in the community, and there's this huge disconnect, which contributes to the reentry mortality that Clemens alluded to. So now we have opportunities to provide case management services that span that gap. We have an opportunity to provide medications, to provide clinical consultations from providers who are in the community. But in order to do so, we've been working through a lot of the challenges that exist, including building up systems that allow for appropriate documentation to bill for these services, to allow for infrastructure, to allow individuals to telehealth or to, engage with their patients while they're incarcerated, to build out timely and screening and assessment tools so we can rapidly reach a population that's eligible for these services, which on our initial kind of estimations is greater than 70% of the jail population. And we're talking about more than about 60 to 70,000 individuals being released from LA County jails every year. So a need to be able to engage with a large number of individuals very quickly and determine their needs and connect them with the appropriate community-based services across a large geography is essentially, the work that's at hand and that we've started to work on. The second area of work, which has been in close coordination with DPSS, our local social services department, as well as our sheriff's department, as well as probation, has been ensuring that Medi-Cal processes are timely and efficient. And this is really kind of the crux of the work in the sense that if individuals don't have their Medi-Cal applications in, if they don't have it suspended in a timely fashion, reactivate in a timely fashion, a lot of this work is impossible. So leveraging Path 2 funds from the state, our work groups have been hard at work in putting some of these workflows in place. The third element of the work, which has been in very close collaboration with our local health plans, has been Regional Justice Involved Collaborative to begin to set up the relationship between everything that's happening on the jail side of the house with all of the moving pieces that are happening in the community, including the expanded network of enhanced care management providers. And there's going to be a lot of intricate work here, just given, again, the breadth of geography. There's differences, in people's history of working with individuals who have, been system impacted, providing trauma-informed care. So gaining familiarity with the needs of individuals that are coming out of the jail space, the need for timely reentry services has been a large part of these conversations. LA County has been somewhat unique in the sense that enhanced care management for the JI population went live last year, but our pre-release services aren't going live until next year. So we've been working very closely with the health plans to come up with creative solutions to start to make those connections, even though we don't have a lot of the tools or resources at hand. And some of that work has included, thinking about how do we submit post-release referrals to the health plans, but then also within our DHS Department of Health Services clinic network, how do we start to build out a model for warm handoffs, including information sharing between clinic providers and pre-release providers, notifications of releases, and any other elements that we can continue to build off of, including incorporation of community health workers to bridge that gap between pre-release and community-based services. And the last piece that I'll quickly touch on for the sake of time is behavioral health coordination. And I can't underestimate the significance of this piece. This is both a significant challenge, but also a tremendous opportunity. CalAIM work for this population comes hand in hand with the requirement for behavioral health warm handoffs for individuals that have identified behavioral health needs. As the previous slide suggested, this is a very large population that historically has received variable levels of support as they transition to the community. So we've been working very closely with our Department of Mental Health colleagues, our Department of Public Health colleagues, to begin to develop integrated screening tools to set up the data sharing infrastructure so we can very quickly and efficiently communicate the identification of individuals with need, identifying the appropriate level of care when someone is released to the community, and to be able to set up processes to be able to QI this work so that we can iteratively improve it as we move forward. So happy to answer more questions, but really just wanted to highlight this is kind of these are the areas that we've been focusing on. It's really been developing new forums and platforms for collaboration across departments as well as the managed care plans, which has been very exciting in terms of the new opportunities for shared work. Building the capacity to serve the eligible population is no understatement. What we're dealing with is, to Clement's point on the histories of mass incarceration, there's also been hand in hand a history of abandonment and divestment of a lot of the services that people have needed in their community. And this represents an opportunity to start building some of those services back. And I think part of this work is identifying where those gaps are and collectively working to fill in those gaps. And lastly, how do we concurrently build up systems for data collection so that we can identify where we're falling short of the metrics and continue to improve on this work in coordination with our county partners, our managed care plan partners, and obviously community-based partners. I will leave it at that and hopefully leave a few minutes for questions.
Great, thank you. We do have a first question in the Q&A box, and I encourage the audience to submit more in the Q&A box. Do all counties go live in the October 2024 to 2026 timeframe?
You want me to take it? So I don't actually know if it's been announced, but I believe when the go live happens, I believe it is all counties with regards to the pre-release implementation. The post-release components of it, the enhanced care management, have been live depending on the county since January. So LA County went live in January. That's more of the implementation of that is more dependent on whether you were a whole person care county that did reentry work or not. And there's been more of a phased rollout that each of the plans is sort of determining independently. But the pre-release, I believe, is going live across the state simultaneously. Someone knows, definitely jump in.
Yeah, thank you. I have a question, which is, if people are interested in informing how this plan is laid out, how can they plug in to your efforts?
So I'm sure you can jump in. I think there's so many different places. I think it depends on who you are and what stakeholder group you represent. I think in LA County, I think we are not at the stage, for instance, if you're a community stakeholder, we have not brought the community fully to the table. I think that's something that we've been discussing, with health plans and others as a really clear opportunity here, sort of engage the community, given all that we sort of talked about and sort of discussing and helping us sort of plan and implement here in LA County. So I would say we need to create that space. If you work for one of the departments or these other things, I think reaching out to your sort of system leads, we do have work groups in place, both cross county and with the health plans to kind of do some of that work. So that's here in LA County. I think if you're in another setting in Southern California, I think reaching out to really the leads in the county depend on who's delivering correctional services from a pre-release perspective. And then on the post-release side, it's really the managed care plan. So depending on where your interest is focused, either reaching out to the county entity that runs your correctional health services in both adults and youth, depending on your interest area, or reaching out to the health plans on reentry ECM. That's what would be good start points.
Great, thank you. I know there's one question in the chat, but I know Troy raised his hand. So Troy, do you want to unmute and ask your question?
Yeah, I do. I think our question is really geared toward the utilization of the PAF dollars, providing access to transforming the health planning system itself. Because within the EACS guidelines, it's particularly for, that $1.85 billion over 5 years to build infrastructure. And if we are year out, and particularly implementation or go live, we have to really create concrete timelines to engage the CBOs. It's clear that community-based organizations are a part of the intention of those dollars. And so far, based on the presentation, what I'm seeing is that there's been an engagement with the health plans and the county justice partners itself, but very little engagement with the community, which is the core apparatus in terms of what we need to engage. So what are the plans of the county to really engage this process of community to utilize those PAF dollars as intended?
So there's different buckets of PAF, I think, that are incorporated within that. I think so. There have been both from the path cited perspective, community-based entities can also apply for those dollars. From a central DHS perspective, speaking from my seat, sort of we've done work to really bring in dollars, whether it be training, capacity building, IT, or other pieces to support our contracted providers in our network. So there's already been those types of investments made in partnership with community-based providers that are contracted with us. I think that when providers come to us, we sort of support obviously their engagement with this process as much as possible. I think on the JI path, which is the Justice Involved path, round 3, which is there's a set of funds that are set aside for the county entities, different county entities, to provide to really set up the infrastructure to do the pre-release support. In LA County, we are sort of challenged in that from the perspective of really bringing in a ton of providers, because we're so geographically diverse, there's thousands of providers in the county. We need to sort of think about how to build the infrastructure to allow providers to access our jails in that way. And so we're really sort of in the first phase, really thinking about investments in things like infrastructure to allow and enable, entities that may be working far from our jail structures to be able to still engage clients prior to release, and trying to build some of that infrastructure. And I think you're right, Troy, there needs to be more conversation and how that might look like in terms of the in-reach kind of components of it. But we're so a lot of this has been coming at us quite recently. So we're still in sort of early phases internally in terms of forming our own kind of really thinking through what the county needs to do in the first phase. And I do think that we need to quickly kind of get to a state where we can do more with community-based providers around that in-reach, sort of the warm handoff components of this work. So.
Excellent. Okay. Thank you so much.
Yeah. Dr. Samra, can you stop sharing your screen so that people can see you a little bit more visibly? Great. Let me see. I think we have another question. What data is the county collecting to track how it is doing on timely processing Medi-Cal applications for intended beneficiaries, and who's tracking?
Yeah, I'll take a first pass at that. So this is in its very early stages. The Path 2 funding, which comes from the state specifically to support the Medi-Cal processes, I believe just came through, or we're still waiting for it to come through. So a lot of it has been the planning of what the vision is going to look like. I think we do have some preliminary data that's locally, our sheriff's department is going to be kind of overseeing and really driving a lot of the screening, evaluation, and application. So we do have some preliminary data there, but part of that funding is to regularly report to GHCS as well as our internal kind of stakeholders in terms of how we're doing with timely Medi-Cal application, suspension and unsuspension. And the one thing I didn't mention is that part of that Medi-Cal process is flipping on an aid code that allows us to bill for pre-release services and do all of the things that we're hoping to do. So we have a lot of motivation to get those things up and running in a timely fashion.
Great. I wanted to note in the chat that Sydney Turner from HealthNet clarified that there is a phased implementation approach for county sort of facilities with regards to the pre-release component. It's designed to be, sounds like a 2-year phase in. So just wanted to clarify that it isn't an all at once type of thing.
Yeah, we could even invite Sydney if you want to come off mute to share. You're more than welcome to.
Yeah, absolutely. Thank you. So the state just released a new updated Justice Involved implementation guide. It's still draft. It's out there for comment, but this is where they specified that, as Shamshir and Clemens were alluding to, pre-release services, they're going to go live. The county behavioral health services will be going live all at once, but then the individual correctional facilities, they get to determine when they're going to be ready, right? Everybody is their own unique facility, their own unique beast, right? So there's going to be an opportunity for them to build what works best for them, drawing down the funding dollars that we've been talking about here. So over 2 years, so I think that brings us into October of 2026, right? Is that 2 years from 2024? Yep, 2026. That's when all of the correctional facilities will be officially live. In the meantime, on 1/1/2024, like Clemens said, Enhanced Care Management's been live in LA. We have been serving the Justice Involved, but statewide, all counties' managed care plans will be serving the Justice Involved for Enhanced Care Management 1/1/2024. So a lot of dates, but I think that the message is we're all building the plane as we fly it. The managed care plans are here to help, and we can serve earlier than a correctional facility is ready, which is good news. Hope that helps.
Great. Thank you. Sydney. And so I think we have time for one more question before we hand it over to Troy. So one question that has been here is, will current providers, organizations inside of the correctional sites be incorporated and or included in these enhanced services? And second question, will the county include them in brainstorming how to serve this population, given that they already are serving them?
I think at least for our LA County jail population on the adult side, our DHS oversees correctional health services, and our correctional health services clinical teams have been kind of leading or closely involved with implementation. So I think for the person maybe asking the question, I think that the work is in the planning phases, and probably through correctional health services leadership, there's opportunities to plug in and engage. I think similarly on the youth, I think it's, there's work with the Department of Mental Health, probation to do that work. So those individuals are at the table. Part of this work does involve individuals coming back from CDCR, which is no understatement. So if the person's referring to CDCR population, I think we have some work to do in terms of kind of building some of those relationships.
Absolutely. And I think also, analyzing the data that comes from CDCR, which when I was doing this work in San Mateo County, we realized that there were different data sources, like what we would receive from them and then what we would hear from individuals once they were out in terms of validating. Any last remarks before we hand it over to Troy and the next panel?
No, very interested to hear the conversation continue. Thank you for having us. Yeah.
Thank you both for being here, for sharing your insights. With that, I will pass the mic over to Troy, who will introduce the next panel. So Troy, take it away.
Thank you, Crispin. I do invite Dr. Hong and Samra to stay on and really help make this conversation more robust, but it's my privilege to moderate the next conversation. And I want to invite the individuals that are participating to the panel to introduce themselves. But I'm Troy Vaughn, Pastor Troy Vaughn. I oversee several organizations that intersect with the criminal justice population in both the housing lens, healthcare lens, and employment lens, as well as other factors. I currently serve as the co-founder and executive director of the Los Angeles Regional Retreat Partnership, commonly known as LARP, and president and CEO over the Los Angeles Mission and Christ-Centered Ministries. And with that, I would like for our panelists who are participating, and Bettina, we can start with you to introduce yourself, your organization, and particularly why this subject matter is important to you and the work that you do in the communities you serve.
Okay, awesome. Thank you so much, Pastor Troy. Good afternoon, everyone. My name is Bettina Lewis. I'm the interim president and CEO of the Los Angeles Christian Health Centers. LACHC, we are a federally funded health center, FQHC. We have two primary clinics. Our main flagship clinic is in the Skid Row community, and then we have a smaller clinic located in the Boyle Heights community. We have several located facilities that are located on the neighboring shelters of Skid Row, as well as we partner with multiple mental health service agencies. And so we do provide primary care services, behavioral health services, case management support, as well as dental services. And so, as you can imagine, being an FQHC clinic, we are designated as what the feds call us as a 330H fundee. And that means that we get funding specifically to support the homeless community. And so this particular initiative by the state and joint collaborations with health plans and community agencies is critical, not only just to our mission of LACHC, but it's critical to what we believe and it's necessary. So look forward to the conversations. And that's all I have for you.
Thank you so much. Chris, we'll go with you next.
Hey everyone, my name is Chris Cervantes. I use they, them pronouns. I'm a mental health clinician at Wesley Health Center for the Full Service Partnership Program. It's a specialty mental health program contracted by the Department of Mental Health. And I'm really passionate about this conversation because I came to this work wanting to work with people who've fallen through the cracks or been systemically disenfranchised. So I'm really excited about the justice initiative changes that are coming. I'm glad to be part of this conversation today.
Thank you so much, Chris. Sydney, we'll go with you next.
Thank you so much. Hi, everyone. My name is Sydney Turner. I am the Director of Public Policy here at HealthNet. We are one of the 2 Prime plans in LA today and in your future as well. A little bit about HealthNet. Medi-Cal is in our DNA. It is my favorite line of business, actually, if I don't mind saying so. We are one of the oldest health plans here in California. We actually were established about 40 years ago. And so we walk the line between being nationally backed and locally based. So understanding the community partnerships and listening to the feedback here is an important component and part of our strategy in terms of how we implement this justice involved initiative. Personally, I'm passionate about this topic because I have family members who are in the system and have substance use disorders. So anything we can do to help the most vulnerable and reduce that recidivism and help people stay well in the community, I am all in. Thank you.
Thank you so much, Sydney. Noah, close us out and then we'll just dive into our conversation.
Yes, good afternoon, everyone. Noah Ng, Director of Enhanced Care Management here at LA Care, the other Prime managed care plan serving Medi-Cal members. I'm really proudly also one of the largest publicly funded managed care plans in the nation. So yeah, excited to be here today. I think we have a unique opportunity, as the previous presenters shared, to transform the way healthcare is delivered, and using Medi-Cal here in the state of California to do that is a wonderful opportunity. I'm really excited to, when we think about transforming how healthcare is delivered, changing it from a traditional clinic setting where folks go to the doctor to get their healthcare needs met, but as we all realize, there's lots of challenges and reasons why folks cannot make it to the doctor, including very many barriers. And so using the CalAIM initiative to kind of transform how healthcare is delivered and not only focus on those medical needs, but also recognizing that all the other social determinants of the health needs are critical to ensuring that we get the health outcomes, is just a pretty awesome and exciting opportunity. And I think it's challenging because it's new to incorporate this into a managed care plan, incorporate this into the healthcare delivery system, which has been traditionally been driven by medical folks and, manuals and guides. And over here, we're kind of looking and trying to see, how do we address homelessness? How do we address recidivism? How do we address many of the social drivers of health that happen outside of the 4 walls of the doctor's office? And so I think here at LA Care, we're excited and ready to do this work and excited to partner with the folks here on the call, as well as other experts and leaders in the community to make it happen.
Excellent. First of all, let me just start off by thanking both Dr. Hong and Dr. Sammer for their presentation, their overview, really, of what steps the county has already been taking and working. And to be clear with our audience, Sydney already alluded to, and our previous presenters, that there is already an apparatus of services happening within the enhanced care management system. And our federally qualified healthcare center partners, and we have, which 2 are on the line, have a unique experience in working with that. In reaction to what was already presented and the fact that there already is an ECM, enhanced care management system, being utilized right now, what are some of the challenges you're seeing from a federally qualified healthcare center's perspective as it relates to things that we can look at and bring into a broader conversation that can help us ward off any potential areas of stagnation within the system? I'll start off with you this time, Chris, in terms of responding to that question.
Sure. So one of the challenges that I've experienced in my program, for context, the population I serve is individuals with high acute complex mental health needs, such as experiencing psychosis, substance use, mood disorders. And so it requires a lot of care coordination, which can look like, meeting the client quite literally where they're at in the community. And that might take some repeated efforts. And if they're not able to be located, we still try again and again. But what that translates to is that all these efforts are, in essence, like unaccounted for. We can't bill for the amount of effort that we're putting into engaging the client and building that rapport.
Excellent. Tina?
Yeah, Chris was spot on with the assessment. I think it's that transition, it's that gap. Oftentimes when we get, from an FQ perspective, when we get the list of individuals that are eligible for services, the contact information is not good, right? Be it that the person did not have a telephone number or an address or what have you. So to Chris' point, when we FQs go out into the community to try to locate these individuals, oftentimes it's impossible to really find someone that's eligible for the services or on your roster. And then the point, once you engage with these clients, it definitely takes the relationship building. So that transition from the criminal justice system over back into the community, there's oftentimes months, if not weeks of elapsed time that we have to make up for to develop that partnership and that, that relationship with the client / patients on our end. So now time is ticking, right, to get this person really engaged and involved into the services that we're able to provide. And then on the back end, that's the front end of dealing with the client once we're able to engage with them. I think on the back end, in terms of the health plan, I think there needs to be some level of continuity in terms of what the health plans are requiring the FQs to do in terms of the services provided. So they're here, so I may as well say it. So, LA Care may have a contract drafted, that we have to meet these, high level indicators or high level key components of the contract, whereas Health Net may have a different subset that we must meet. And then the payment isn't matching. To Chris's point also, we don't get paid for those touches. And so that becomes definitely a barrier as well. And with the program being so new, there's all this reconciliation data that we have to submit from the FQHC side that's not adding up to the health plan. And so definitely more infrastructure within our organizations will be critical in order to make this program a success.
Excellent. And so we'll give Sydney and Noah an opportunity to respond to that in terms of how we're seeing it in real time, both from the work that the county is doing and then now how it's interfacing with the FQHCs as it relates to reconciling the work that's being done, which is actually being able to be billed. How do you see the benefit of having more community conversations and more community partners involved in the conversation to help us ferret through what those initial barriers that we're seeing are happening?
You like to go first, Noah? I saw you were off me first.
Sure. Yeah, I know. I agree with all of that. I think one of the things that we see too at the health plan side is that in the newness of the program and in the kind of ever-changing guidances that come from the state, it's kind of sometimes can be challenging to keep up. And those changes are good, right? These changes are good changes that are being taken because of feedback from the community, to your point, Troy. Like, I think the community speaks up loud and makes recommendations, and the state changes those recommendations. And so but when things change and you look at a large managed care plan serving 2 million folks with infrastructure and IT, to make those changes and implement those changes requires, it's hard to be as nimble as we want to be. But I think this is part of being in a new program and trying to do something brand new in this healthcare space. I think those that want to do this work have to be prepared for these kind of stumbles and these challenges that we're going to face and work through it together to roll up our sleeves and make this happen. There's no easy way to kind of incorporate housing and all of these social services into a healthcare system that has traditionally left that out. It's going to be a challenging work to get this in and to keep it in, so that for generations in the future, what we're building right now will exist. That when you have your insurance card covers not just your doctor visits, but all aspects of your health. And that's really what we're trying to do here. And so it's challenging. I know when we talk about the specifics of the question regarding the outreach, to Chris's point, how they do the outreach, and then how do we make sure that you're fairly compensated for that? That sometimes is the hardest point. As someone who's been a care manager myself and has worked in an FQ whose focus was on patients that weren't showing up to the clinic, I recognize that it is the hardest part sometimes, is that outreach and that engagement. And I think it's because of the feedback from folks on the call today and others that the state has changed their guidance. And it's actually said that outreach will be now a covered and paid part of the enhanced care management program. And managed care plans are currently required to pay for that outreach. And so at LA Care and HealthNet and others, we're all trying to kind of adapt to that change and figure out ways to get our providers that payment so that they can get reimbursed for that outreach. So I think speaking up in spaces like this, as well as, one other thing I'd like to call out is PASS CPI. So PASS CPI is a local group here in LA County that gets together and talks about all of these issues, whether it's issues about how we can have more alignment across the managed care plans. And it's not only for providers that are currently serving ECM or community supports or one of the CalAIM programs is for folks that are stakeholders or are interested. So we encourage folks to also sign up for PATH CPI to attend their regular meetings. I think one's happening tomorrow. It's a great place to kind of collaborate with others and make sure your voices get heard so that can kind of roll up to the state and impact those policy changes.
Excellent.
Thank you. Just agree with Noah and appreciate you guys being transparent and honest about what the challenges are. You are definitely not wrong when it comes to outreach, because HealthNet had the experience with the Health Homes programs here in LA County, and we were closely watching the Whole Person Care program. We knew that outreach was a thing that we needed to pay for. I agree with you. It is likely not enough for the number of efforts and touches and outreach attempts that you actually have to conduct in order to make contact with that person and establish that relationship. Hearing this feedback is really helpful because what the managed care plans do behind the scenes is we talk to the Department of Healthcare Services, and through our utilization data, right, all of the different claiming things that you guys do to share with us all of the different touches and care coordination efforts, we're advocating behind the scenes saying, hey, we appreciate the rate, but this isn't enough. This is actually what the level of effort really is. So I know it's not a good answer, but the way that we structure our approach to billing, though it might be different, there's a method for that madness, and there's a reason. And it's because we're trying to gather the information that we need in order to continue to advocate for rates. When it comes to collaboration, managed care plans, we didn't collaborate as closely as we have been for the last few years. And it's actually been really exciting and fun. And I've gotten to know my buddy Noah over here a little bit more closely. So instead of competing, we're collaborating. And you're right. We are not perfect, but the things that we can align on, we are really working hard to do. Sure, things might kind of get misadjusted as the state continues to fine tune the requirements and reach standardization, but just know that we are listening and we are trying to streamline those processes to the best of our ability. The reality is we are two separate health plans. So the things we can streamline, we will. But the things that we cannot, we are a unique entity and we have to ingest that information or that data or that claim slightly differently. But I want to give an example about how HealthNet's been listening. So early on, when the transition from whole person care to enhanced care management occurred, we realized that some of the processes we thought were a good idea would get in the way of a smooth transition. So we waived some of those operational processes mid-year. When we brought them back in, we heard from our provider community, hey, it actually worked way better the other way. Can you get rid of this administrative burden so that we can just get to ECMing right there and improving access? And we listened and we did change our process. So, there was a mention of the list that we do send our ECM providers. So for HealthNet, if that individual, that member is on that list, we're not asking for the FQHC, the clinic, to come back with an authorization. We're saying, go forth and ECM, send us the claim, and we'll build the authorization on the back end. So it's not perfect, but we're learning together because this is all really new. When I try and explain to my family, what we're doing, I say, well, it's kind of like doing your taxes for the first time ever in your life, right? Like that's kind of what a managed care partnership could be sometimes. It's frustrating. You feel like you're dealing with the government. But the reality, again, is that we are passing down requirements that the Department of Healthcare Services are putting on us. And we're trying to find the best, most effective way to do it. We're not going to always nail it the first time, but we're willing to listen and adjust and make some changes.
That makes sense. One of the things that kept bubbling up in our previous discussion and our panelists, and then still here now, is this need for community engagement at a high level, right? Like, I think it's important. How do you guys envision really bringing the community into the work? What are our outreach strategies now? Our communication strategies that are in place? Is there an opportunity to use some of the PATH dollars to really create a more robust communication strategy platform to engage community now? Because I hear everybody saying it's very complicated, and it is very complicated. And if we wait to July 2024 to start educating community-based organizations when we're trying to go live in October 2024, we're probably going to have a problem. So that's a part of the question. And the next one is, how are we actually using the work that we use? Because when we start saying that it's new, but we had, health homes, we had whole person care, we had all these precursors to CalAIM, how are we really utilizing that data to inform what we do now? And particularly through our community engagement strategies. And I'll start in the reverse with you, Sydney, and work backwards.
That sounds good. So starting with, what we're doing to engage with the community, I think, I know that HealthNet, our strategy and approach has been to partner with community-based organizations, FQHCs, clinics who do this work today. We are not trying to recreate the wheel, but learn from that wheel, if you will. So we're willing to be at any table. I think the challenge is in LA, there's quite a few tables to sit at, but if you're interested in having one of the managed care plans, especially HealthNet, come, we would be happy to come and have those conversations. In terms of outreach, we and LA Care, we've kind of aligned on a process where, providers can reach out to us and say, hey, I am interested in serving as an enhanced care management provider, whether it's for the justice involved population or maybe another. So we have a streamlined process where we share information with each other. And I can drop a link in the chat. There is a provider interest form, and you tell us a little bit about yourself. And then there is a lengthy certification application. It is a lot, but it is worthwhile and necessary because it gives us a better understanding about where your practice is at, what your model is, and be transparent about where you still need to build or fill gaps maybe in whatever it is, because we're here to go at your pace. There's an opportunity for CalAIM, incentive dollars to potentially fill those gaps. And then one of the things that we've been doing are these CalAIM roundtables to make sure that we're aligning on some of the investments that are happening in the community. Noah mentioned the past CPI meetings, which is a really great place to say, hey, I'm here, I'm interested, or I want more updates. We also, for HealthNet, we've implemented regional models. So we have a vice president and medical regional lead here in LA County who is very passionate about connecting with the community and getting to know everyone. So I'm happy to share my contact information and hers because she really does want to meet you all and find out how we can continue to partner. So it's not perfect, but it's growing and it's getting better. But definitely want to understand what tables are available. And if there's any seats for HealthNet, we'll come join you.
Yeah, excellent. We're gonna make it happen.
Let's do it.
Do it.
Oh yeah, I think Cindy said it all. I think sometimes we're looking to figure out which tables we need to be at the managed care plan side. And to your point, Troy, like this is the lessons learned for whole person care and health homes. It's really important that those lessons are implemented and thought through, and so we don't either make the same mistakes or rebuild something that's already been built. And so it's really important that we pass that information along and make sure that the managed care plans who are going to be responsible for a lot of that post-release work get that information, and we're reaching out to the right folks to get that. Because we're a county that did whole person care before, we have some experience, but I think we definitely need that and are thirsty for it. So I think it's a two-pronged approach. One is we invite folks to come to town halls. We have regular town halls that we do together with HealthNet and the other managed care plans. So that's a way to just get the word out. Whoever wants to show up, sign up, comment. We talk about what managed care plan is like, what CalAIMs, what the different programs, how you can plug in, whether as a provider or as a referral source, right? Because not everyone is ready to be a provider or wants to be a provider. But folks know and are doing this work and want to make sure they're connecting, folks to these services and these benefits. So that's one way. So it's kind of these open forums that we do. We've hosted a few, or we'll be hosting more towards the end of the year, coming up in the next couple of weeks, and we can make sure those invites get shared out with this group. And then Sydney said, being asked to be invited to those tables wherever we can. As Clemens and Shamshir shared earlier, there's a lot of collaboration and coordination happening with the county to make sure that bridge between pre and post release happens. But all the other work that's happening already in the community, but to your point, I think we are eager to kind of join those tables as well.
Excellent. Bettina?
Yeah, so when I think about community and what's happening in all the different tables, I think Noah and Sydney definitely, hit the nail on the head. There's so many seats at the table, right? So many tables for us to engage and collaborate and partner. And as a FQHC, partnerships for the community is so critical. So it's even more critical for us to continue to have strong relationships with the managed care plans, as well as even with additional FQHCs in the communities that we're serving. I think one is to ensure that, there's no duplication of services, or why create the wheel when the wheel is, we have a squeaky wheel, just, rolling really, really well in some essence. But the work is definitely critical, and it's necessary for us to continue to come together. I think as an FQHC, when I think about just the basis and the premises of why FQHCs were founded was on a social justice component. And I do believe that we FQHCs are the bridge to getting folks the services that they need, to getting them the full wraparound care that they need, to, partnering and communicating with the health plans, engaging with the health plan. So on all collaboration is necessary, not only just for the ECM program, but just off of just the basic continuity of care for our patients, being the voice for our patients, advocating for our patients, ensuring that they have the medical services, because it's all great once you put things down on paper, right? But is it practical of what we're able to do? And I think that practicality, the FQs have a different perspective, and we should be able to inform policies. We should be able to inform decisions, and we should have a seat at each and every table, because this is our community that we're serving.
Excellent. Chris?
I don't think I have anything to add to this question. I think Bettina said it all.
Okay. One of the things I just wanted to add is, because one of the complications I see with CalAIM, and particularly, is the idea that from an ECM standpoint is more clinical and healthcare focused in nature, right? But there's this non-clinical component and this other asset that is community support, right? There's 14 community supports that's embedded within this opportunity here. And I think a lot of the conversations that's happening in the community, and particularly, is within that sphere of medical or clinical, right? And it's not bridging the gap to those people or organizations that are providing the community support services, and particularly. And we need to kind of blend the two worlds at some point, right? That we have an understanding. And this is where the education component is going to have to be really stressed, right? Because you're going to be, I think it's easier for FQHCs and particularly and organizations that are hybrid in nature, that already deal with the population, to kind of understand the sophistication of billing, right? But then you have this other group that's providing this, community support services, outreach and engagement. They're doing all of this stuff that is in there in terms of helping people to acquire housing and through navigation services, accessing those resources, whether it's housing deposits or whatever it is, right? Sustaining them into the units and those other services that are there. And for this particular population, and particularly the justice population, we need to create a forum that is having that conversation. And maybe, and I'm interested in hearing the thoughts about the team in terms of using the FQHCs as they were intended to do in the community as access points, right? Because, that's what they are particularly, and then partnering with other organizations in a shared partnership agreement to do some of the other services and engagements. I know that FQHCs can do a lot underneath their configuration, but how to find partnerships. I think the county alluded to what they're doing with their existing networks, and they're really creating, I think, a system of what it could look like where you can have a lead. The county in that particular case is the lead, and they have a network of organizations that are in that. And many of those organizations provide a particular type of housing or services, but then they provide other services too. It's those other services that they're providing that we need to figure out how we can really begin to increase. And just interested in hearing your thoughts about creating, as we're having this conversation, what do you guys think about that? And I would even invite two previous panelists to come in and chime in on that one too, because we need a system that makes sense. And that's not duplicative in nature, but is utilizing all of the resources. And I have a feeling that we're creating a siloed system that is more geared toward clinical and medical lenses, which it should be, because that's what ECM is. But these other supportive services that are here, these community supports, are important to this process. And how are we going to engage organizations to actually do the work?
Would you like me to start?
Yes, go ahead. Go ahead, Cindy.
Okay. You're absolutely right. Creating that cohesive whole person care approach and feeling is exactly the intent and goal of CalAIM. I think it'll take a little bit to get there, but I think we're off to a heck of a start, considering maybe we're starting at ground zero, right? There are definitely some clinic structures that do that. I call it a hub model. Maybe that's not the official term, but there are those hub models out there. HealthNet actually has a few of those creative contracts with providers providers where they're the administrative entity, right? And underneath them, they have the community sports and ECM providers. And so they take the burden of authorizations, claims, all of that part of it off of those providers so that they can just go forth and do what they do best, which is serve the most vulnerable people and population. In terms of connecting, again, I'd love to come to the table, but a couple of things that HealthNet has done is we've done some in-person meetings, engagements, actually in LA County, and then we've also done it in collaboration with LA Care as we do these trainings with the enhanced care management community supports providers. Some have been in person, some have been webinars, but when we had this engagement opportunity, we did a little bit of speed dating. So we said, hey, ECM and community support providers, it's time to meet each other and you have 10 minutes. And they bounced from table to table, introducing each other just to get to know one another. And I know work has shifted to this virtual nature, but in-person connections really still do mean something. And we do value them here at HealthNet. So yes, I think there's opportunities to grow. We're interested in creative models of care. You just explain it to us and we're usually okay with it after a few questions, right? But yes, no, I think CalAIM allows for that creativity and implementing a model that works best for that community or that community-based organization or that FQHC or clinic system.
Nice.
Can I just say, I really like what HealthNet is doing. I really appreciate that approach because what Troy mentioned earlier, it was a bit easy for FQs to follow this wave, right? Because this was the work that we were already doing even before we were getting funded for it as being a community system, right? I remember as early back as 2006, 2007, we had at LA Christian, we had case management services that we weren't able to bill off the services, but because we had a social worker who knew how to get folks housed, we really maximized that benefit for our patients. That was just like an added service that you would get if you became our patient, right? But I think to Pastor Troy's point and to Sydney's point, this particular model is definitely going to have to take ongoing collaborative efforts. There's so many agencies that reach out to LA Christian. They may do the housing component or they may do the employment component, but they need to get connected like with the medical piece of it. And so having an agency such as HealthNet or LA Care to continue to bridge the medical team with the service providers outside of medical, if you're following me, I think that is going to be critical. And I wonder like what type of resources besides the 10-minute speed dating, right? What type of resources can the managed care plans continue to offer on a regular basis just to ensure, one, that there's no duplication of services and that all service providers are still having a seat at the table to really wrap around these clients that we're serving.
Yeah. That's great. And I want to invite our county partners. And I saw your hands raised. Don't put them down now, y'all. Come on in here. Jump in these waters.
Yeah. Sorry, go ahead, Clemens.
No, I think Ms. Lewis is asking the perfect question, right? Which is how do we sort of fund this, right? How do we bring resources to this? And I think what we're in a sense saying is how do we bring resources to these expert community organizations that are already doing this work? And I think the FQHCs are great examples of these types of organizations, but there are other organizations that don't have that clinical background or the infrastructure that really came from these communities. They that are really best positioned to do this. And right now there isn't a payment mechanism or a resourcing mechanism to bring them in outside of saying, LA Christian will take a payment and then subcontract out a subset of the outreach and engagement services to this entity, which is doable, but it puts a lot of demands on LA Christian. And it's something the county does on the community support side, and it's very burdensome administratively. And, we take it on for our networks and those sorts of things, but it's not easy, right, to create this hub and spoke unless we're willing to not only resource the entities, but all the administrative components that need to be built to sort of support. So that's what I would say to add to it.
I think the only thing I'll just briefly add to Clemens' point, I think, we get to this predicament that we're in right now related to reentry and system impacted communities because communities have been made marginal. So I love the idea of broadening the conception of community to include service providers, but also how do we think about ways of incorporating people who are being served by these programs so they have a voice in iteratively improving these programs? And I'd love to kind of be in conversation about how that happens, as well as groups that, to Clemens' point, maybe are not service providers, but have been organizing with folks who have been impacted by the system and have been at the forefront of kind of reimagining what, our local carceral landscape looks like. But just want to echo support for, this idea of working together moving forward.
Yeah, I think it's great. And I think a part of it is, how large LA County is as a whole, right? And the diversity that it has. And how do we begin to figure out how to incorporate those diverse perspectives into the conversation? And really why I'm espousing is that we start sooner than later, right? I think that right now, as you guys have already articulated, is so complex. And I think really beginning to understand, I know that it's already been said that there are already forms that the plans have in terms of the engagement, but I don't know if the broader community understands how to engage it, right? Like, I think that's where, when I talk about communication, how are we actually making sure that people are more informed and being able to access first existing resources and then come to the table and then as a lens in terms of how do we begin to bridge that gap right now, right? In terms of incorporating, the BIPOC community into this conversation, which is, we know by data, is the one that is probably most impacted. And so how are we going to begin to broach it? Can we learn from recent lessons, not just whole person care, but COVID taught us lessons, and we created communication apparatuses that helped us to reach those, highly impacted communities. Is this an opportunity for us to use some of those lessons as well in terms of communication to get more people involved in the conversation? Anybody can jump in.
I mean, I think the answer is absolutely yes. You're right. There are some collaborations existing and ongoing, and how you navigate to get a seat at the table. It can be a little bit challenging, but I think I'll commit to a follow-up, from a HealthNet perspective. We do our own forums, we do these collaborations as well. And so I will follow back up with the ITEP team on how you can more effectively engage with us directly. I think also another opportunity to collaborate, and I am saying this because it's another thing that I own and am proud of here at HealthNet. We host community advisory committees. They're quarterly. We have one specific to LA. You will be talking to me and other subject matter experts here at my managed care plan. And so it does give you an opportunity to understand our strategy, specifically to what HealthNet's rolling out, and then also influence it. If you've got a good idea, I'm going to take it, run with it, bring it to our internal teams and see if it's something that we can't operationalize. So I think it's, engaging with the community and then how you want to engage directly with your health plan. But there are a number of ways. I think it's just, unfortunately, are you interested, and do you want to be harassed by us and engage like this directly? And will you let us take up that much time on your calendar? Because I will do it. So.
Yeah, I'm ready. I'm ready. I do want to ask this, and while we got our other panelists in here, I think it's important that we talk about lessons learned. I had the privilege of serving with Clemens when we were doing our whole person care pilot here in Los Angeles County. And we learned a lot, but we also made some mistakes, right? Like, I think it's important that we talk about what those are so we don't repeat them. So what do you think are some of the mistakes that were made during whole person care? And then what solutions do we need to now put in place to address them?
I'll start with one, and I think to me, it's what we're talking about right now. I don't think that we really sort of engage the community and our provider base, right, in a discussion about what capacity we need to build in the community to serve this population better, and didn't commit enough resources to invest in building that capacity. So I feel like, in some senses, that was a missed opportunity for us to really think about these dollars that were available to build our community infrastructure, right, to do this going forward. And I think if we had done that differently, right, in the reentry space, we have funds now, and so it's not done. Like, there's still an opportunity, but we might be in a better place today, right, to really take these folks coming out of our jails right now, and they have done better over the last 5 years. So I think that's kind of a key lesson. And I think we need to sort of bring together the clinical and the social care pieces and these expertise. I think with whole person care, we're only able to really invest in the social care, but we could have invested in the social care plus the capacity building pieces that would have brought this together. And I think in some senses, that's the opportunity in front of us now, is how do we do that? How do we bring the strengths of the different entities in our respective communities and bring it to bear on improving the health of this really, really marginalized population?
That's real. I appreciate the honesty and transparency in that. From the QAC standpoint, you guys were a part of that system. Now, did you feel included in the whole person care process during that time, or did you feel excluded from the process?
I'll just speak. I wouldn't necessarily say excluded or included, but it did feel, it felt piecemeal together. It didn't feel as a cohesive level of teamwork, if you will. It just felt patchwork. And I think you mentioned this earlier, Troy, that if we don't fix it right now, we're headed down that same route, sort of speak. And so I think the communication needs to, while we're trying to get all service providers together to clearly communicate on what each agency has the expertise and how do we collaborate to make this program beneficial, I think we need to take a step back too and also better educate our patients that this benefit is available to them as well. And what does that look like being a health plan member, a managed care member, and having this benefit? Because just on that education piece, that takes a lot of time just from a service provider as well. And then also, convening something with the health plans and the service providers that will be beneficial on a regular basis, not just one and done, not just 2 times per year. It's almost as if we may have to have quarterly meetings until we get our rhythm. And I think once we get a rhythm going, this program would definitely be sustainable. But under that whole person care, it felt fragmented. So I wouldn't say we were not included. I wouldn't say that we were disincluded. It just felt like you were getting information from just so many places. And it's like, where do you run with it? Where do you go with it?
Noah, what are you thinking, Noah, from the plan's perspective about whole person care?
Yeah, I think I'm newer to the plan, so I think I don't have a reference point here. So I'm going to have to have on some of my colleagues that were a big part of that transition, supporting that transition. But I was working in an FQ who was one of the first clinics to participate in whole person care, Housing for Health, ICMS, and we were really proud of it. I think we appreciated the flexibility and the feedback that we were able to provide, both, LASA and our DHS colleagues on that implementation. I think as an FQ, we realized we were coming from it from a standpoint of very much our patient care and understanding how to transition to providing services beyond our patient population. We felt overburdened by just keeping up with the patients that needed our care. And then to think of ourselves as well as now positioning ourselves as a community-based organization that's serving the entire region was something that our leaders it was tough for our leaders to kind of understand. And it's a different way of thinking, right? But it was a unique opportunity. And I think, Troy, to your comment earlier about the need for FQs to play a key role in this, I think there's a whole other webinar content here, I think, or a whole other meeting to have out of this to talk about the role of FQs and not forget how FQs, why they were started and why they're funded and how this all fits into CalAIM. Because it's not only the lessons learned from whole person care that we want to include, it's all of these other projects and programs, right? Whether it's federally funded, state funded, locally funded, how do they all kind of fit together and support one another? So absolutely, and I think very much in agreement and figuring out ways that we can support in doing that. The other thing I'll call out is it's also important that we have these local conversations, and I don't want to, take away anything from these local conversations that need to have, and LA Care is committed as well to sit at the table and bring also our plan partners or the other managed care plans to the table to talk about this and learn and be a part of that conversation. But I also want to talk about the upstream impact. Many times managed care plans are dealing with policies and procedures and requirements that come to them baked. It's already baked by the state. They've kind of come to these here's what you need to do managed care plans, right? And so sometimes we have an opportunity to actually impact some of those changes in the policies and the way these programs are designed. And I think Sydney mentioned earlier, the JI policy and operations guide is under draft comment right now. So this is a unique opportunity for stakeholders to speak up and be a part in how these policies and operations guides are developed and created at the state level.
Excellent.
If I can add, so I was here at HealthNet while Dr. Hong was forging a path with whole person care. And I think it's really important to note and celebrate your vision, actually, just specifically for LA. They're one of the few whole person care programs that actually chose to take on the justice involved and fine tune and enhance those partnership with the correctional setting. During the whole person care process, we were sharing lists. We didn't have as much oversight. I wasn't bothering Clements with so many requirements, but they really did forge a path for the rest of the state to understand how this should work and where to begin and what to avoid, if you will. So I don't know that there was a bad outcome of it, other than this team really went forth and conquered and then shared those lessons learned statewide. Every time I think the Department of Healthcare Services asked you, Dr. Hong, to come and present at some other seminar, maybe a few times a year. Totally agree that the local conversations need to keep going, and our policy journey with the Department of Healthcare Services is not over. It feels like there's updates to the requirements once a quarter, which just makes these partnerships even more important. And, of course, when the department makes a change, the managed care plans have to prepare a training and communicate, educate, and do all of those things. So there's lots of steps in that process. And I'll say that I'm incredibly grateful for the community's patience with us as we interpret these requirements, ingest them, because they come very quickly. I think a really good example, and we were talking about how do we make each other more aware of who's addressing maybe the social drivers of health versus the clinical parts and pieces. The state is fine-tuning their data sharing requirements. And more recently in September, the managed care plans are being required to share member information files to the community support providers. Some of us did it already. Some of us had some special partnerships, but this means like broader, more statewide, all of the entirety of the LA community supports network will now have better insights as to who's receiving enhanced care management. Maybe there's another community support out there. So I think my ask is patience. We're doing our best, but keep coming back with that feedback and telling us what's real, because words and policy paper and all plan letters is one thing, but how it actually works on the ground is a different thing. And the more that the managed care plans hear from you all, trust me when I say I take your comments to the Department of Healthcare Services directly and do our darndest to advocate for maybe more time or reasonable requirements. But all in all, it's really exciting work. It's hard work. We just kind of have to stick together and continue to be understanding of each other as we keep trying to build this plane as we fly it. I know everybody's tired of that saying, but it is true.
No, it's definitely true. And I can attest to the fact of the leadership that Dr. Hong, exhibited during whole person care and continues to do in this process here. I think this gives me confidence as a community leader, having worked closely with him through the years, that, this process is in really good hands in terms of the county perspective, and really opening to really creating this pathway of community engagement. And with that, I think it's important that we, have a conversation about people with lived experience in this conversation, right? Lifting them into this space, because I think their voice is going to be invaluable to helping us to understand the engagement. We've learned that. I think lessons that we learned that were successful is this idea of community health workers in this space. We already talked about the transition clinic network, lessons learned in terms of bringing it here to Los Angeles County. And we see the benefit of people with lived experience now embedded through our contracts. And now even DACS is offering up peer support services certification, which is a billable component. How do you guys envision that working in this process? Peer support specialists and now that emerging.
So correct me if I'm wrong, but the peer support specialist is actually going to be under the behavioral health department of the county. But I think it's going to be potentially really important to ensure that those behavioral health linkages occur. Maybe similar, but not quite the same. There's the community health worker benefit, where we are absolutely looking for providers with lived experiences to step into this space. Members always have a right to choose. That enhanced care management is voluntary. Maybe they don't want that level of care quite yet, but they appreciate the community health worker approach to, some navigation, education, a little bit of assessments and things like that as well. So I think it's going to be important that we continue to talk to each other and figure out how we weave all of these services together so that our members really feel like that they're streamlining their navigation versus receiving maybe 6 different outreach calls from six different points of contacts.
That's right. And avoid the duplicity, right? And really understand. Right. I think the reason why the conversation is needed now, because we want to avoid confusion around who's playing what role, what's billable, how it's billable. If organizations serve a dual role, and being contracted directly with the county, but maybe have, and if we're able to create a system, a relationship with an FQAC, for example, from other services that are not tied to the county's billing apparatus, how do we envision that process happening? Can organizations work in those dual areas and spheres of service delivery? Oftentimes you're going to get an organization that's doing both health and behavioral health, right? And so there's an integrated health model. And so are we open to having these conversations? Should we be having these conversations now rather than later, as we see these kind of dualities happening? And how do we avoid duplicity in the space and limit confusion?
I think one thing I would add is maybe more at the micro level is how this workforce integrates into teams that are maybe operating more in a medical model. And I think often we add the community health worker. Oh, can you hear me? Oh, yeah. We add a community health worker to the team, but we don't provide the proper supervision and don't invite them onto the team and give them power or share that power with them and recognize the expertise that they bring, having that lived experience and what they bring to the table. And I think too often we introduce them into a structure that's not ready to really incorporate them and take the sort of really bring them onto the team and have them be sort of a core, almost leading part of it. And I think that's a piece that's often missing. And it requires training, it requires culture change in the organizations. And so I think one of the things I would say is we bring on funding streams or whatever, it's all sort of siloed in buckets, but we often don't provide, in addition, like on top of that fee for service, the right training of supervisors, training of organizations. Really that understanding and that sort of value proposition isn't there, and people are just sort of doing it because there's a funding mechanism. And I think that's a really problematic space to sort of work in, because we're talking about people who are from these communities, who are some of the most marginalized people, and we're throwing them onto teams where they can have things like systemic racism sort of be the subject to that. And so I think we really need to think about how we do that, right? How we build the capacity and make sure that this is done in the right way. And then it kind of speaks a little bit to why the organizations that are already from the community are often best positioned to hire and bring these folks on, because they understand more what it's like. And so I think, so just a few comments there in terms of how I think about the role of the CHW, but the value is definitely there. I don't think there's any doubt, especially in these spaces of engagement. Like, we're just not going to engage people coming out of our jails unless we have this workforce that understand what it's like and has that lived experience.
100%. You need the community to reach the community, right? Speaking of community and the population, our undocumented population is going to be eligible come next year. And how are you guys talking about right now in your conversations incorporating, do we have capacity to absorb that in our system now? And what does that look like? And are we prepared to really to absorb them into the system and provide the services that they now be eligible for, that they weren't eligible for because they have access to Medi-Cal?
I would say, I'm sorry for jumping in before you even ask anyone. This is—
Go ahead, jump in.
I'm like,
I love the conversation.
I would say here at LA Christian, this is a topic of discussion probably every other day. We definitely have the capacity because we're already serving this particular population. And in fact, I'm working out of one of the clinic where we have a huge undocumented population. I would say my concern for this population is not the services received, but on the back end is the county. It's more of the county and the state connecting so that we can ensure that these patients are getting the Medi-Cal. So I'll just speak on the My Health LA patients, right? What does that transition look like? Is the county ready to transition those patients fully over to us? What type of gaps in cares are they would they potentially receive? Will we have the supporting documentation needed to get them enrolled into Medi-Cal? So it's one thing of being eligible for Medi-Cal and for these services for the managed care plans, but do we have the resources to go get them the documentation needed to enroll into the program? That's a concern that I have. And then also, are they in limbo with their care from transitioning from a county funded, grant capacity over to managed care? Do we have the manpower? My organization does not have the manpower to get folks not necessarily enrolled, but to follow them through to ensure that they go from the county's My Health LA program to the state's Medicaid program, because I wouldn't be able to bill for services, or that's all free, if you will, from my end. So once they're into managed care, I think everything will go smoother. It's just that transition to getting them from My Health LA over to managed care. And that's the concern that we have here at Los Angeles Christian. It's that gap, about a 60 to 90 day gap for them to get that insurance enrollment.
That's huge. Chris, what about you?
I don't have enough information to speak on like the more like macro level, but I think on the micro level, like we are already serving undocumented members of our community. Concern that I do have is around there being enough like linguistically appropriate care. That has been a barrier that I've seen in our work here.
Yeah. And that's one of the questions that's in the chat right now that John poses in the diversity. How are we handling people with unique needs, not just disability, but he talks about disability, but, like large print and recording information. How are we prepared to handle diverse populations now with our communication apparatuses? What are your thoughts? Like, how is that happening? I know the health plans probably have something now to engage, but is that now incorporating the education around CalAIM and how that, I know that the county also has communication apparatuses, but is it now being utilized to translate into those populations how they can access the resources and the such?
So Sydney from HealthNet, I have a few answers here. I want to address the continuity of care concerns that Bettina was raising up. So yes, this very last cohort of individuals with unsatisfactory immigration status, they will be transitioning into managed care. First, they're going to get an opportunity to choose, and those letters will be translated for them. If the Department of Healthcare Services is aware of their preferred written and spoken language, it will be sent in that language. If it's not, it's as simple as that person, that individual, calling up healthcare options or their county and asking for help in a translation of those materials. We're all required to do that and provide that, including large print. So once that individual chooses, or maybe they don't make a choice, we're going to look and see if maybe that there was a prior plan experience or a family linkage. And then finally, of course, if no decision is made, there's something called a default. I won't get into the tactics of it, but basically you will be either assigned to HealthNet or LA Care. In this transition, if the people who are serving them now are billing fee for service, so billing the Department of Healthcare Services directly and getting reimbursed, that data will be coming to the managed care plans. So we're going to understand where those services have been rendered in the last year, who their doctor is, and then managed care plans will be required to support those continuity of care requests. So if an individual is transitioning and maybe that they are acute or very chronic and let's say that they're in the middle of a transplant, right? That information is going to come over to us, and the managed care plan is going to reach out to that provider and say, if they're not already in the network, and say, hey, would you like to join our network? If yes, great. If no, there are other protections in place for these vulnerable members to ensure that they maintain that coverage and that provider of choice. If we can't come to an agreement, we'll work with the member to find another provider of their choice. So there is a data sharing effort expected. It's not going to start really occurring until we know which of the individuals belong to either HealthNet or LA, because you got to respect those PHI HIPAA laws, right? But then we also have processes in place to support this transition. Our goal is not to have anybody slip through the cracks. If you're a provider out there, Bettina, Chris, if you find somebody who slipped through the cracks, please let us know, because we want to jump on it as quickly as possible to reassure that individual. So I'll touch on the continuity of care.
I appreciate that. I think for me, I can already foresee those patients that are going to slip through the cracks. And that's going to be our homeless patients, right? Our patients who do not have an address, our patients that are not receiving ongoing communication, not only from the state level, but the health plan level, that they're only getting that communication when and if they come into the health center to receive medical care. And for us, for LA Christian, that's thousands of patients that are not, that are going to fall into the gap. And right now, I don't have the staffing capacity to catch those patients, but, we're going to try our best. But nevertheless, I just think about when we did Affordable Care Act back in 2014, it was one thing to educate the patients on, you have a new benefit, and this is what it means to be enrolled into Medi-Cal. So I can already see that happening with this undocumented population. What does it mean from going to a My Health LA undocumented, uninsured capacity to a managed care capacity? Who's going to do the education with them on receiving specialty services? You're no longer going to the county system. Now you're going to private specialties for the ongoing specialty care or what have you. And then how are we, what is the health plans or even the state? How are they going to reach this group that's unreachable unless you do some boots in the ground and get out there to meet with those folks?
Another example of why community partnerships are so
Yeah.
important.
Yeah.
Right now, this is it. I mean, and then I think we can underestimate some of the lessons we learned during COVID, which is the cultural sensitivity to this conversation. Being able to have now people give access where they already have trepidation against the system as a whole and not really understanding what that's going to mean for them. So we got to have some real clear understanding of how we want to engage the community. We had to change our whole communication strategy, and our organization had the privilege of leading the communication strategy for the county in terms of how we wanted to engage populations and using people within the population to actually do the engagement, because what we found was just within the household itself, there was cultural differences, right, in terms of understanding. And so we needed to make sure we had conversations that were happening, that were bridging the gap for access for this particular population. And so I think it's important that also is a consideration in terms of how we want to engage this population, is understanding that many of them, are operating outside of the system, and now we're asking them to come inside of the system, and they already have trepidation against the system, and they're not interested. We got to ensure that they understand that giving information, giving their name, and creating unique identifiers for them is not a means to deport, right? And I think, and we got to understand that these are real fears, right? Like that people have, and we want to make sure that we're dealing with it now, in my opinion, and understanding those cultural sensitivities so that we can be ready to engage.
Yeah.
So, John,
one thing
go ahead, Noah.
Oh, just real quick on that point. One area that I think we'll also just want to highlight is LA Cares Community Resource Centers, which are 12 physical locations located across the county that are actually providing services like enrollment support for folks that are undocumented or just folks that have been left out of systems of care. This is not locations that you don't have to have an LA Care membership or have Medi-Cal enrollment to join in the activities of the community resource centers. There's health classes, there's other events, but there's also folks there that can support with Medi-Cal enrollment as well as CalFresh enrollment, because recognizing that sometimes it's challenging to get online connectivity, right? Having internet, right? Thinking about the barriers that are set up right at the beginning that can impact someone's ability to actually get into the benefit, as well as support with all the many documentations and copying of many forms that are needed or additional support. So I just want to call out community resource centers as another great useful tool for folks to tap into.
Excellent points. I did want to raise up a question that's in the chat. John, he says, if he was pre-release, Medi-Cal eligible individual waiting release, how exactly would he be enrolled in one of the managed care plans, and who would be asking him basic questions about and where living, et cetera, and who exactly will be communicating past history and ongoing medication to his new provider?
Go for it, Shamshir. I see you off mute. You're going to have a better answer than me.
I'm not sure about that. Some of this is evolving, but I think the vision right now is that, unfortunately, if someone's incarcerated, there would be a process to determine if they're eligible for pre-release services. And like I mentioned earlier, we're anticipating the vast majority of folks will be eligible if they have any co-occurring health or behavioral health condition. In which case, if the person has a previous assignment with a health plan, they will retain that assignment at the time of release and likely retain their provider, unless for whatever reason they're going to a different geography or a new county, in which case I think there's some details to be worked out there. If somebody wasn't on Medi-Cal, then part of the Medi-Cal processes on the pre-release side would be to submit that process or submit that Medi-Cal application. And once it goes through, an auto assignment would happen, essentially, based off of some of the criteria that were mentioned earlier by our health plan colleagues in terms of determining which plan they should be assigned. And the idea would be that at the time of release, they can plug into ECM as soon as possible. But I'm sure Clemens, Noah, and Sydney can provide some more details on what happens on the post-release side. But the last thing I'll say is that part of this work will be data sharing both from the community side into the carceral setting. So if somebody's incarcerated, we're hoping to have systems in place so we can figure out which medications, the care plans that were in place prior to incarceration, but then the reciprocal as well as if new medications were started, then that information would be shared back to the community-based provider.
Excellent.
If I could just add, I think something unique and that many advocates probably here on the phone fought for is member rights. And that means a Medi-Cal member can choose, well, in LA between HealthNet and LA Care, and they can change their mind each month. So you're not locked into one managed care plan for the entire year. You do have the right to choose. In advance of the pre-release services, my recommendation would be reach out to the county social services office or check out their website. I'm hearing that the portal is actually really helpful, and then you don't have to wait on the phone too long. There's also a state service called Healthcare Options. It's a 1-800 number. They'll help navigate that. But if it's easier to call, no, I'm going to be bold, either LA Care or HealthNet. I know we have processes in place where our call center agents will connect you with Healthcare Options, and they can help you make a determination and a choice. Noah and I, or LA Care, HealthNet, we can't tell you who to choose, but it would be an honor to serve.
Excellent. So as we come up to the close of our time together, we got Bettina joining us back. I want to give you guys, each, about 2 to 3 minutes just to share with the audience in terms of what do you hope to get out of this full process. At the end of this 5-year period, what would you like to see in Los Angeles County and across the state with this opportunity that's been given to us? And, what are you looking forward to learning from this process? What is the ultimate measure of success for you in terms of being involved in this process? And since you're at the top of my Brady Bunch box, Chris, I'll go with you first.
I think I'd love to see more cohesion. I think with the members that I serve, there's a lot of confusion. They're in the middle of a really large web of people that they're beholden to. They've got their, probation officer, public defender, substance abuse counselor, intensive case management services people from the Office of Diversion and Reentry, their mental health team. It's just such a large list of people that they have to correspond with that, adding additional service like enhanced care management can sometimes feel a bit confusing. And then on the service provider end, I'm also trying to figure out who are all these people and what is their role, similar to how the client's trying to figure that out. So I would just love to see a way that we can all, the theme of today has just been collaborate more smoothly.
Excellent. Thank you. Sydney?
When I think about the Justice Involved initiative, it would be amazing if those recidivism numbers just went down because of our building the bridge or strengthening the bridge and the better offering of care coordination of services to keep people well in the community, meeting those goals that they want to meet, whether it's clinical or non-clinical. I think, I think and I know that we will all still be talking to each other, continuing to improve this initiative and effort. So, ongoing patience and understanding. I think as the Department of Healthcare Services kind of finalizes their policy, it'll actually allow us to get to a stable level of norm, whereas we're constantly tweaking and pivoting, trying to adjust for the new requirements. So I hope that this collaboration, ongoing collaboration with Clemens, his team, the county, and the community keeps going, and that you really do view your managed care plan as a partner and somebody who wants to be here to help, because that is absolutely true.
Excellent. Noah?
Gosh, so much. But also I feel like maybe, I think if we think about this 5 years from now, where would we want to see this? I think for me, it's that we've laid the foundation for future generations to totally transform how healthcare is delivered. That no longer is your insurance card just your kind of, your key to access your doctor or your pharmacy, but it actually gives you your access to other rights that you have as a human being, like housing and food, that are all kind of incorporated into the CalAIM initiative. And so JI, our Justice Involved initiative is one component of it, but I would like us to see that we've laid the foundation over the course of 5 years to transform how healthcare is delivered in this country. and using California as a model for other states to see that this can be done, and it does lead to those good outcomes that we believe in.
Excellent. Dr. Hong?
I really like the word cohesion. I think part of cohesion is sort of seamlessness. And I think one of the issues that we have when people come home, which will help achieve, I think, Sydney's vision of, reducing recidivism and depopulating our jails, is to make sure that when people come out, they're connected to the right level of care and the right set of services to meet their needs upon release, like right at release, and that there's a warm handoff of that or an in-reach capability to do that, because I think that's going to be really the trick to really improving the health of these populations and decarcerating, right? Which is a critical piece. And the second thing I'll sort of throw in, which hopefully we won't need it at some point, but I think probably in the next waiver we unfortunately will. But I think really just completely tackling and doing away with the inmate exemption, which in my mind is one of the most, frankly, racist policies that we have, right? In terms of who we incarcerate and the fact that we don't have federal funds coming to provide healthcare in the jail. So I think the 90-day pre-release piece is a really critical component, and it's a great starting point, sort of that foot in the door. But I hope that in the next waiver, we can kind of go all the way and provide the full scope of services when people are incarcerated.
Love. Dr. Samra?
Yeah, I think I'm just going to keep building on this theme of cohesion. I think this kind of, again, I'll say the predicament we're in comes on the backs of, decades of kind of inadequate infrastructure in the community to serve populations who needed it most, and a lack of coordination and trauma-informed care. So I'm excited that, this isn't kind of the end-all be-all in terms of reversing mass incarceration, but this serves as a touch point that I think can not only serve folks, but also serve to transform our institutions, whether it's folks on the pre-release side, folks in the clinic setting, to really kind of reorient and recenter kind of populations that have been pushed to the margins historically. So looking forward to new opportunities for collaboration there.
And Bettina?
I think everyone touched on what I was going to say, but I think Inoa said some really excellent areas that I just want to highlight. I think that the cohesiveness, as well as our indicators, our health indicators, we see a tremendous change. And then I just envision a world where housing equals health and health equals housing, and seeing those two married together ongoing, and just continuing to have a community, a true safety net for our patients that we're serving. But the panelists all said what I was thinking, Pastor Troy.
I'll just close out by thanking each one of you for your service to this community. I think a lot of times, the stuff that's not seen is, this work that happens behind the scenes. And many people see people that are connected to, big health plans or clinics or county systems as anti-community. And I would suggest to everybody on this call that's heard this message is that we're all our community, and that we all are concerned about this issue, and that if we continue to form levels of collaboration and discussion through healthy dialogue that doesn't look to blame anyone, but to look to solve the issues, then we'll get there together. For me, I envision people coming home with the right to health care. I think that engagement needs to happen prior to their release, and this is going to give us more of an opportunity to build upon that, not just here locally, but across the state. I think once they're released, that we'll be able to provide them comprehensive care ongoing, and to be able to build on the work that we do with Healthy Homes to make sure that they can select where their provider is located in those communities, and then we be able to build community for them within those communities by attaching them to community support services that are available through this apparatus. And so I envision us really using this to really help our community heal and to be healthy. So many in our communities, and we're talking about the reentry population, but many of the populations of focus in Calhoun are part of that population as well, right? We have youth and children and senior citizens and people that are connected to this, obviously people experiencing homelessness. And so this intersecting point of understanding how we're able to touch the populations of focus in this particular need for the reentry population, I think it's helpful. And I think that you guys and the work that you have already done or continuing to do here is what's needed in this space. So I want to thank you for your service. I want to thank my friend Crispin and his team at ITUP for bringing this forum together and their work, lifting their work up here in this space to really be a convener in this space and really allow us to, share our thoughts and let this not be the end, but the beginning of rich dialogue and collaboration and conversation so we can actually develop the things that we're talking about here, which is this level of community engagement that every participant is respected when they come to the table and that we all get there together. So again, thank you for your service and the time that you spend here this afternoon. I'm sharing both your heart and your expertise. It's been invaluable. I'm certainly to the hearers. For those that remained on the call and those that had to get off, I'm sure that as this conversation goes through the airwaves, that people will it will resonate with people, that it's time for them to get engaged in the process of transformation that they seek. So again, thank you all. And with that, Crispin, I turn it back over to you, my friend.
Great. Thank you. And I just want to take a moment to also thank all of you for your great insights today. I think it's really helpful. At ITUP, we're committed to bringing communities together to really talk about implementation. This is where health really happens, right? At the local level, that's where patients that's how their experiences are shaped. And so this population in particular, it's not like we're just going to hit a light switch and everything's going to work. I recognize it takes a lot of work. And so I think that this conversation was a great beginning for that. And so besides the speakers, thank you for being here. Our audience, thank you for sticking through to the very end. And lastly, to ITUP staff for, sharing all the links in the chat and for helping set this up. So I thank everyone, and I hope you have enjoyed the rest of your evening. So we'll talk soon.
All right. Thank you.